being that it is Thursday morning after the 8:30 news, time for another edition of What's Up, Doc, where we get to spend some time with the healthcare experts at Mercy Health. And this comes at a great time because I was looking at an email, Joe, that you and I got from a listener complaining that we do not spend nearly enough time discussing urogynecology on this show.
Oh, I got that one earlier, too.
And, they said, listen, when I listen to two men in the morning, I expect there to be at least one segment per hour on urogynecology, and you guys are really dropping the ball.
We're going to nail it right here today.
Do what we can.
Yes.
Our guest, who I'm sure is regretting this appearance right away as we speak, would be Dr. Sonya Ephraim, and she's with Mercy Health, Chief of Female Pelvic Medicine and Reconstructive Surgery, Urogynecology. Dr. Ephraim, good morning to you.
Good morning.
How are you this morning?
I am doing great, and I'm so happy to be here and hopefully answer a lot of good questions for you.
Oh, boy. Good questions.
You'll answer questions. I don't know if any of them are good.
Well, you always have to be so specific. They've got to be good. All right. Tell us what a urogynecologist is. Joe and I had a wager. I bet it was someone from Europe.
Yeah.
Joe says it's not. So who gets the $20?
Yeah, so unfortunately, no, not from Europe. Urogynecologist is essentially a hybrid between a urologist and a gynecologist. So I started off as a general OBGYN, and then I did additional training and fellowship to subspecialize. So now I just treat disorders of the female pelvic floor, like incontinence, urinary incontinence, fecal incontinence, pelvic organ prolapse, which is basically when your female organs are falling out of the vaginal opening, pelvic pain, sexual dysfunction, those types of things.
So let's rewind a little bit. How did you get into medicine first, and what led you to the path to this part of medicine?
Well, I got into medicine because I had a passion for it from a very, very young age. One of my dad's favorite stories to tell is how I wanted to be a doctor since I was about 8 years old. Actually, he loves to say that the first thing I ever wanted to be was a garbage man. And
I get it.
that didn't pan out. So the second thing that I wanted to be was a physician. And I loved playing with toys that had to do with anatomy. Do you all remember that toy called the Invisible Man?
Oh, yeah.
Yep, that was my favorite toy as a kid, and I would take all the little parts out and paint them and put them back together, and mine was a female, and it had a pregnant belly. That was like when I was 8 years old, my favorite thing.
Wow.
So,
did you have Cavity Sam in the operation game, too?
Yes, I did.
Nice.
Yes, I sure did.
Yeah, you were the kid who never never the sides, I'm sure, and never got a zap.
Exactly. I had skills from early on. So, and then, I decided, I just pursued it and had good guidance from my family. They exposed me to mentors, so there's no other physicians in my family, and who helped to guide me and get me into medical school, where I definitely found out I had a love for female healthcare. I love taking care of women. I bond with them very well. They always tell me things. I go to a party and people tell me things that they might not usually tell someone else.
So you get the good dirt, don't you?
Exactly.
Oh, good
exactly.
For you.
I'm sorry.
Sorry.
No, real quick. Just something fascinating about your story there. A lot of the doctors we talk to, a lot of people on this show we talk to, and we talk about how did you get into it. It's a family business. A mom and or dad were in it, and that's how they got into it. You said no one in your family in the medical profession. I just want to ask you, this is kind of off topic, but is that a benefit or a hindrance? Did that allow you to maybe explore other avenues that maybe other people that it's a family business are steered towards one specific practice?
I think it was probably both. It was probably a benefit in that, like you said, I was more open to choose my own path. I didn't have anybody saying, oh, we already have a internal medicine practice and you're going to join us. Mm-hmm. I said, but then on the other hand, my family is mostly in law, or attorneys and things. They really had no idea, but they had resources. So they hooked me up with friends and colleagues who did have the resources to get me the mentors that I need, because mentorship is huge. You really need to have somebody to help guide you down the path.
Do lawyer families look down on you if you go into medicine?
I think it's the other way around.
Okay,
yeah, I think it's the medical families that look down on those who get into law.
Okay.
I'm just guessing.
That's good.
Yeah, no, my dad is extraordinarily proud of me, so it's really cute. I'm 43 years old, and he still likes to brag on me.
Well, we dads are like that. Yeah,
Uh-huh.
I don't think he's going to outgrow that. I know I'm not going to as well. Now,
Yeah.
let's talk a little bit. What should someone expect? Now, when I say someone, what should a woman expect during her first visit with a urogynecologist such as yourself?
So usually by the time they end up at my door, they've already seen a primary or a general gynecologist and voiced some kind of concern. So my history and exam can be pretty direct. So they would come in and be greeted by one of my MAs or nurses who will just get some basic information. We try to make them feel as comfortable as possible because we know it's a sensitive area to be talking about. And then when I come in, I just do a really thorough history, focusing on the issues that they have, and then a physical exam. We test their bladder function, nothing very invasive on that first visit. And then I educate them on all of their options. So everything I do treats issues that affect our quality of life. So there's nothing that I'm going to say you have to have this treatment or you have to have that treatment. I educate them on the disease process, and then I educate them on options that will improve their quality of life. And we come to a conclusion together as to what's going to be good for them, because every woman is different, right? We all have different values, different goals, and everybody has a different outcome they're looking for.
You mentioned some embarrassment that goes into this topic, and I'm sure you discussed that with a lot of your patients. I'm sure a lot of your patients probably could have benefited from seeing you earlier in their life than waiting so long. What do you suggest to people about broaching this kind of sensitive topic with their general practitioner or who else? What's the best ways for a woman to cross that first bridge into seeing you?
You know, I think, number one, in this day and age, we all have to advocate for ourselves, right? So getting a physician that you have a good relationship with, making sure that you trust your primary or you trust your gynecologist so that you can have that open dialogue is the first step. Then advocating for yourself and saying, hey, I have this issue. You know you're in a safe space, that information is not going to go any further, and you should be able to talk to your provider about it. And then also one of my biggest things is educating providers, because you'd be amazed how many primary carers and even gynecologists are unaware of what I do and that I am a resource for them. So I like to educate the providers and let them know that these are some of the most embarrassing topics a woman can address. And most women go years before they are comfortable enough bringing it up. So really, I want to educate providers that when a woman comes in for her annual exam, you should be asking the question, do you have any issues with your sexual health, your pelvic health? Do you leak urine when you cough or laugh or sneeze? Those are things that really the provider should bring up as well.
And the last thing that you talked about, that leak a little bit, would cough, laugh, sneeze, that sort of thing. I just read a piece within the last couple of weeks that said that is so far more common than especially men would ever realize.
Oh, definitely. I think the data is 1 in 4 women will have some kind of pelvic floor disorder, including stress incontinence and prolapse. And by far, stress incontinence is the most common thing that I treat. And even with treating that, I still have a lot of women who come in and say, oh, I thought it was just a normal part of aging. And it's not. It's common, but it's not normal at all. And it's so simple to treat most of the time that I just wish I had a much larger audience to be able to shout it out to women. You don't have to suffer. You don't have to wear pads. You don't have to watch those Tenna commercials with the woman laughing and peeing her pants in the movie theater and think that that's how your life has to be. We can treat it. We can fix it.
You mentioned stress incontinence.
I'm so glad she gave us that word. It's such a much more radio-friendly word to use.
Yeah, stress incontinence is a wonderful way of putting it. Then there's another one, urge incontinence, right?
Correct.
What's the difference between those?
So stress incontinence comes from physical stress on the pelvic floor, force, like coughing, sneezing, laughing, jumping up and down. Urge incontinence is leakage that happens when you can't get to the bathroom fast enough. Normally, people get an urge to have to use the ladies' room And it comes on slow. Like now, if I had to go to the bathroom, I could hold it until we're done with this interview. But people with urge incontinence, that urge comes on like a train. You cannot stop it. It is so strong, they'd have to take this phone right into the bathroom with them, and it is something that cannot be deferred. It comes from bladder spasming. It's harder to treat. It's a chronic condition, so they'll be dealing with it for the rest of their lives. But it is something where treatments are available, and a lot of the treatments work really nice. One of my favorite things is injections of Botox into the bladder.
Really?
Yeah, I bet that was part of the piece that I had read, too, that one of the headlines inside the piece was the amazing uses for Botox beyond wrinkles.
Mm-hmm. Yep, it's such an effective treatment, and it allows women to avoid having to take an oral medication, which then you have room for patient error. People forget to take it, or maybe they have side effects from it. They don't like it, or maybe it's expensive to pick up from the pharmacy. So, Botox is a treatment that most women will come in about once every 6 months and get an injection. The injection takes about 1 minute, and they get good results. And so they don't have to take oral medications, and they can have good relief from their symptoms of urgency, frequency, waking up at night to pee, urge incontinence. It's just a huge effect on quality of life.
Now, just going back to the stress incontinence specifically, you and I are the same age, and some of my good female friends that I've talked to, and we have a very honest relationship, have confided to me. Yes, this happens to me at our age. I just wondered, like you said, it's a big thing that it's the most common thing that you treat. And how many women don't go in to get it treated because they don't think it's that big a deal, or it's too much of a pain to deal with, and it's not going to work right away. I don't want to bother myself with it. How quickly from when they see you for this are they getting better?
So treatment of stress incontinence is a procedural intervention. So either a minor outpatient surgery or procedures in the office that I can give. And so from the time that they come and have their first appointment with me, there may be some additional testing that I need to do. That would be a second appointment. And then after that, we pick what treatment they like and perform it. So it can be relatively quickly, by the time they come in. And the downtime is what a lot of women, especially in my age group, because we're still active mothers, we still have 10,000 other things on our plate. Nobody has enough extra time to be down recovering from a big surgery. This is not a big surgery. This is something where you can get up, drive your kids to soccer practice the next day, keep doing your job every day. It's not going to hold you back. So it's something that a lot of women are just unaware that these options are available and that they are so straightforward.
And once again, I think part of it might fall into the trap that we have seen forever, is that the woman in the household is caring for everyone else and making sure everyone else is covered and putting herself on the back burner.
Oh, exactly. And, it's unfortunate I have some patients who, do delay treatment, or, they're taking care of everyone else, or maybe they have a job that they don't have time off and they're nervous. And those women, too, I have other options. I have in-office treatments. So, my biggest point is get it evaluated. It doesn't hurt to come and make an appointment and see what your options are. You would be surprised at how, I love to think outside the box. I'm a woman, obviously, myself. I know the things that we're going through. So I want to make treatments as accessible, efficient, and with as little downtime as possible.
You sound like just the ticket for many people who are probably listening this morning. We're like, man, I need to see her. I need to see her. Do they see you? Does it take a referral? Can they make a direct appointment? How does that go, doctor?
So that just depends on their insurance. A lot of people can just make a direct appointment. Some people, their insurance does require that their primary care puts a referral in. That's something that they can find out pretty easy. If they call our office and schedule an appointment, our people will be looking into that, too. So if they did need a referral, they would reach out and tell them, hey, we want to schedule your appointment, but you got to get a referral. And that's easy. The primary carers don't hesitate to send that in.
All right. Sure. Dr. Ephraim, you have been outstanding, wonderful, using smaller words for guys like us. We appreciate all of that. I'm sure that going into this, you're like, oh, God, I got to talk to two dudes about this, and I hope we acquitted ourselves fairly well.
Oh, yeah, I just pretend you're like my husband. He gets to hear all my great conversations all the time.
Well, we'll swing by the house, talk kegling with him a little bit.
Awesome. He is 100% educated on it.
I bet sure he is. Dr. Ephraim, thanks so much for your time. We'd love to have you come back on with us again, and have a great rest of your day.
I'd be happy to. Thank you so much for having me.
Oh, glad to do it. Dr. Sonya Ephraim with Mercy Health, 851 News Talk 1440 WROK.